I was asked to talk a little bit about caring for infants less than 24 weeks and their families. And I want you to remember three things. Everything else I say, these are the three main points, and I don't want you to forget these. The first is simply that infants born before 24 weeks are not just smaller, extremely preterm infants. The pediatricians exist as a specialty because they said to their adult colleagues, children are not just little adults. Neonatologists have done this and said babies are not just little kids, and preterm babies are not just little babies. I want you to know that our tiniest babies, our babies less than 24 weeks, are not just smaller, extremely preterm infants. Also, their outcomes depend on what we do, and we'll talk briefly about that. We need better evidence to support safe and effective care. And also, we need to continue to ask families what they need. Those are my three take-home points, but please don't leave yet. I have been very interested. I've been reading some old histories of neonatology and thinking about where all of this started and how this line of work and taking care of tiny babies really fits in. And so to start today's talk, I thought I'd talk a little bit about that. It's easy to forget, but we haven't been around for very long. This is from the Google Ngram viewer. This is a really neat Google product. You can look up any word that shows up in the entire corpus of the English language that they've scanned from the various world libraries. And you can see that in all of our English language literature, you do not see the word neonatal intensive care until about 1970. You do not see the word NICU until about 1970. We exist as a specialty now about 50 years. This will actually be our 50-year anniversary here in 2025 for the board exam, for when we became official. This is a relatively new trend. And if you look back historically, some of the famous first units, the group in Toronto, the group at Vanderbilt, Bill Silverman at Columbia, they were setting up in the very early 60s, 1960, 61. And about 15 years later, in 1975, is when you have the first board exam. Like I said, just 50 years ago this year. And you have about 150 NICUs that Dr. Butterfield identified in the entire continent of North America. Fast forward to today, and my most recent estimate is about 850 level 3 and level 4 NICUs in the United States, so excluding Mexico and Canada. Here's another way to look at some of those data. Back in 1975, we had our first board exam, and by 1981, we just look at the very lowest group here, I think a group that we all universally recognize needs a neonatologist involved, our VLBW infants. There were 83 babies born VLBW in the United States per neonatologist. By the mid-90s, that number was in the low 20s, then in the teens. Today, it's around 10 to 12. And there's about 4,500, 4,600 of us here in the United States that are active, up from single digits and dozens in 1975. Here's another interesting way to look at this, and I think it's really helpful to zoom all the way back. When we look back just 100 years ago, the infant mortality rate in our country was somewhere between 80 and 100 babies per 1,000 live births. So if it's 100 babies per 1,000 live births, another way of putting that is 1 in every 10 babies died. That was the state of the world in our country not that long ago, like maybe your grandparents or your great-grandparents' world. Certainly your grandparents would have grown up thinking like that from the people that they learned from. And look at all of these changes. You have antibiotics, you have massive public health interventions, antibiotics, vaccines, improvements in water and sanitation. When we talk about neonatology, we're here. This is the impact. We didn't have NICUs until, somewhere in here. It depends on where you draw that first line, but those very first ones, before we even called them NICUs, were around 1960. And this is what's happened to mortality since then. So I think this is relevant to the point that I'd like to make about how these are not just extremely preterm babies. Stick with me. But going back here to say 1970, the infant mortality rate's like 25 per 1,000 live births, 4 times smaller than it was at the turn of the century. And now, in this century, this goes through 1995, so zoom way in, it's about 5. So the infant mortality rate during the era of neonatology in our country has gone from 25 down to 5. And that's the same sort of proportionate change as if from 100 down to 25. But the people who started this field back in 1970, who came up with terms like extremely preterm, who wrote the first textbooks, they were in a slightly different world of what we did. So one of those famous first textbooks given to me by my mentor, Ed Bell, it was his in 1971, says the lower limit of viability is probably around 28 weeks, at which time most infants weigh 2 pounds, 4 ounces, or 1,000 grams. Those are all numbers you know. Extremely low birth weight, extremely preterm. This is where that terminology comes from. This is the beginning of our field, and we drew a line and said that's really rare to survive below that. That's extreme. And that's what we called it. And we've stuck with it now for half a century. We've had other categories. Those early neonatologists discussed late preterms and moderate preterms. You see how small these are. Very preterm, and then this extremely preterm group. Today, fast forward 50 years, there's no viable report. There's no report that I've found believable of babies surviving at 20 weeks. Maybe there will be someday. I have not seen that yet. There are a lot of case reports. We published a series that involved dozens of babies surviving at 21 weeks. So that is now a fact in many parts of the world. But those are babies that you could still count. There's just a couple few dozen that have ever been reported. When you get to 24 weeks, more than 50% of babies survive in most NICUs in developed high resource countries. Certainly this is true in the United States. And here you've got this group that fits right in between at 22 and 23 week. And that is why I want to focus on this group, is because they're really just kind of stuck in the middle. In terms of actual numbers, it's about 4,400 babies at 22 to 23 weeks born in our country each year. That number's dropping a little bit, which is a good thing. There's an incidence of about 1 in 1,000 births. That's about the same as the incidence of Down syndrome or fetal alcohol syndrome. And I point that out to say every pediatrician has seen those. And I think in 10 years, every pediatrician will also, have seen a baby born at 22 or 23 weeks. Astoundingly, this is 1 in 7 infant deaths. And that's because, as I showed you, the infant death rate now is about 5 per 1,000. It's no longer like it was in the 70s, 25 per 1,000, or like it is in some other countries, up at 50. We're really fortunate to have so many of our babies survive. So this is really, I think, also a frontier and an important aspect from a public health perspective, that this is really where our, in public health metrics, a large proportion of our infant mortality comes from. And to my knowledge, I'd be happy to see some other source. It's hard to find a perfect way to tabulate this, but to my knowledge, this is, if not the largest contributor, the largest single diagnosis accounting for death, greater than congenital heart disease, for example, or HIE in our analysis of birth certificates. It's certainly in the top few causes of death now for infant mortality. When you look at how we've taken care of babies at 22 and 23 weeks over the years, this is an old paper we published about 10 years ago now. Babies in the neonatal network, hospitals that I think anybody in our country would say, hey, mom and dad, grandma and grandpa, our baby's getting some of the best care in the country. These are all outstanding hospitals that have very good outcomes. But astonishingly, have very different practices, or did at the time, at 22 and 23 weeks. So you can see here these dots represent the rate of active treatment at each hospital at each week. In 26 weeks, all the babies at all the hospitals practically got some sort of active treatment or postnatal life support, you could call it. At 25 weeks, same. 24 weeks, a little bit of a decrement. If you look at more recent data, those are all up. So 24 weeks looks like 25 and 26 weeks in 2024, 25. Um, but look at this. When you go to 22 to 23 weeks, you have variation from 0% resuscitation to 100, and you really can't have any more variation than that. One other interesting thing, these data are now a little bit dated, 2006 to 2011, but even then you had the occasional pushing of the boundaries. We published this in the New England Journal. There were a couple babies at 21 weeks where resuscitation was attempted 10 to 15 years ago now. The babies did not survive, and we described their cases in that report. Fast forwarding now about a decade, here is when that paper came out. There were also, because it was not only that paper, there was also the NICHD workshop, ACOG, and AAP published guidelines around that same time that said, 22 weeks could be considered for resuscitation, which was not really the practice prior to then. NRP updated their guidance within this few year period as well. We just published this, and this is just to highlight that starting around 2015, you had a 400% increase in the rate of NICU admission at 22 weeks, a four-fold increase, which is really astounding. You also see a big increase at less than 22 weeks, but that's that series I reported. It's only 38 babies. And so when you went from essentially 0 to 38 over the course of some years, it looks like a really big trend proportionately, but the numbers are really still very, very small. And you can see that it's been a slight uptick at 23 weeks, but it's been very consistent. There weren't any sudden changes. Something I think is really important, and I mentioned this before, is that the number of babies born at 22 and 23 weeks is actually decreasing over the years. You don't think this as a neonatologist because you see more of them in your unit today. But when you look at birth certificate data, there's a big drop. We published recently that if you look at a level 3 or level 4 NICU in the United States, well, 22 and 23 week babies are about 1 in 1,000 live births, like I said, similar to the incidence of Down syndrome. They make up close to 1 in 100 NICU admissions, 1 in 30 NICU bed days, and something that really floored me. We went back several times to check the data because I did not expect this, but 1 in 6 NICU ventilator days. And I'll show you some data as to why that seems to be the case. It's because the duration of ventilation is much, much longer than even other extremely preterm babies. These are just hot off the press here in the last month or so, I believe. And this is Jeffrey Horbar and Erica Edwards, who published from the Vermont-Oxford Network what's happened in the United States from the Vermont-Oxford Network, from the Vaughan perspective. And what I wanted to show is that you have now 75% of babies born at 22 weeks in their cohort received active resuscitation, which is a huge increase. And you see that now about 25% survived to discharge. You also see this huge difference, 25, 50, 70, 82 across these gestations. So there's a really ton of change. A baby born at 22 weeks is meaningfully different too than a baby born at 24. So this is really the state of where things are. Taking on our history lens here again, which I thought some of the fellows might find valuable. We've had these debates before in our field, before my time. This is Dr. Stallman, who set up one of those first NICUs in the country in in Nashville at Vanderbilt. Um, and here she is writing in 1984, before some of you were probably born. And I'm just going to read this entire thing because I think it's the exact same question that many of us are asking right now about taking care of babies at 22 and 23 weeks. So she writes, our longitudinal data in babies weighing less than 1,250 grams at birth are clearly tentative. We've been able to observe 132 of these survivors between 76 and 82. As expected, the severity of illness, effort required, and complication rates are significant and similar to the data of others. The number and severity of complications, and in this very low birth weight group, the IQ, vary with birth weight and gestational age. It's impossible to draw firm conclusions about outcome at this time. Only a few of these infants have been observed until 5 years. However, as in infants with higher birth weight, there is an apparent rise in IQ with postnatal age. And this population demands continued observation, but birth weight less than 1,250 grams is no longer a death warrant or an inevitable predictor of severe handicap. So I think that's where we are at 22 weeks right now. Um, I think nobody in this crowd, I hope not amongst our fellows, would say that being born at 1,200 grams is a death warrant. 90% of those babies now often survive. So things have changed a lot since Dr. Stallman wrote this, and we're currently undergoing one of these same changes. It's not just us in the United States. These are guidelines published from different parts of the world, in Germany, in Sweden. This here was the British Association of Perinatal Medicine in 2019. Consider active treatment or active management for premature babies born at 22 weeks. So other countries are going through this same thing. These are the data here that have been published, very similar to what I showed you here in the United States, where around 2015, 2016, things changed. Here is, just pay attention to this purple line. That's 22 weeks in the United Kingdom. This is a population-based data set for all fetuses alive at labor, so it includes stillbirths. And the number that received any sort of active treatment after, you see the BAPM guidance, the British Association of Perinatal Medicine guidance, go out. It more than doubles. Boom. And it's continued to go up. So this is an active discussion, for example, in England. Here it is in Sweden. You saw a similar change really in the earlier 2000s. Population-based data. Prior to 2004, they didn't collect in their public registry births at 22 weeks or before. But starting in 2004, because some babies were surviving in NICUs, they started to include babies born at 22 weeks. And you see on this graph now across their entire country, which is only about 10 million people, about the size of Illinois, you see a survival rate of over 50% at 22 weeks. We have very little to support what we do. So these changes have happened largely in the absence of really good evidence. We did do a systematic review. We looked at all of the trials that included extremely preterm babies over a decade. So good for us neonatologists. We did 200 trials. We randomized 32,000 babies who were extremely preterm across these trials. But the babies who were born at 22 and 23 weeks are a drop in the bucket. 1.4%. So if you were to say, oh, I have a trial that in extremely preterm babies, you should do X, start the fluids at this. You should, provide delivery room CPAP prior to intubating. You name it. All of those trials are really for bigger babies. If they included 22 and 23 week babies at all, and most of them did not, the number of babies was so small that any effect was really washed out. So we don't know what the most effective treatments at 22 and 23 weeks are for the most part. And a lot of us are really working on anecdote and experience, which are inadequate. And I think it really behooves us to recall that the most effective and safe treatments at 26 and 28 weeks, like I pointed out, might not be the same at 22 and 23. And why is that? Because as I said, babies born this early are not just smaller, extremely preterm infants. And now I'll tell you a little bit about that. They're not just smaller, extremely preterm infants because they're born for different reasons. These are data from Japan, from their very nice data set that we've used. And you can see here uh, premature rupture of membranes, as the cause of delivery, and chorioamnionitis correlates with this quite nicely, in fact. Vast majority of babies at 22 and 23 weeks are born for these reasons. But when you get way up here to 30 weeks gestation, say, or 29, you're seeing a lot of gestational hypertensive disease. There's almost no delivery due to preeclampsia at 22 and 23 weeks. So the babies come into the world for different reasons, much more likely to have an infection intrauterine. And that really bears out when you look at culture positive early onset sepsis. These are wonderful data from Dustin Flannery, a colleague at CHOP, who's shown that the rate of culture positive early onset sepsis at 22 and 23 weeks is 3 times higher than it is at 26 and 27 weeks. So if you had a quote unquote extremely preterm baby antibiotic stewardship program, your pretest probability for an infection is hugely different when you look at this group versus this group. And it may not make sense to have the same sorts of um, protocols in some areas. Transepidermal water loss, I think, is one of the most interesting differences in this group of babies. That means the insensible water loss that occurs through evaporation at the skin. And these are older data. You don't actually see 22 and 23 weeks here. These come from Gunnar Sedin, who was at the University of Uppsala in the 80s. And he didn't have babies that young in his cohort, but you can see the difference at 24 weeks. And what you see is that this change within this group we call extremely preterm is as pronounced in terms of the amount of water that evaporates from the skin as it is from 28 weeks to 42 weeks. So a lot of centers say have a humidity protocol. We put on the same humidity for every baby less than 28 weeks, for example. But that is as big a difference as you see from 28 to 42. So it's very possible. And in fact, there are two trials now going on in the world looking at whether we should use higher humidities or different humidities at the very earliest gestational ages, different than, say, 27 weeks. You all know this if you've ever taken care of a baby this early. I think it's the most obvious thing when the baby comes to you, how different their skin is. And it's translucent and it is wet. It's glistening. You can see, a very bright red because of the translucency. You can see the capillaries. And that's because of the lack of keratin. And the keratin here is what really keeps in the water. It develops over time. If you pay attention to the baby in the incubator every single day, you'll notice that the skin loses that glistening appearance and starts to become more opaque. And that's the keratinization that happens from the air being dry. But the baby who's born at 25 weeks has a bit of keratin. They're not born so red and shiny. Here was the ventilation slide I mentioned. I find this really interesting. You can see again why we should talk about 22 and 23 week babies differently. These are data from the entire country of Sweden over several years, and they looked at how many babies on any given day were on mechanical ventilation, by which I mean intubated ventilation. There were after birth. And so I'm going to look here at 22 weeks, which is the blue line. And you see that on day 0, every baby was intubated. Not a surprise. Few people, maybe feeling a little bit gutsy here, tried to extubate during the first week. 100% of them were reintubated. So none of the babies, again, by 2 weeks, 100% are reintubated. So they weren't ready to be extubated. Here they are again at 100%. And then finally, you do start to see some drop off. But when you look at the median, The average duration of intubation at 22 weeks in the entire country of Sweden was around 50 days. And when you look over here at 23 weeks, that's around a month. And at 24 weeks, it's around 3 weeks. These are normative data. This doesn't tell you what to do, but I think it should give you some pause that, hey, this group of babies is kind of different than, say, at 25 weeks, where the majority of babies are extubated within a week. So they are different. That's one of those things. So if you have an extremely preterm baby protocol, to get the tubes out as soon as you can, might fly at 25 weeks. Apparently, it flies really well in these data at 25, 26, 27 weeks. By the time you're at 26 weeks, most babies aren't intubated at all. But it's not going to fly at 22. Some things depend on the baby, but some things depend on what we do. And I think that's a really important point. That's that point that Dr. Stallman brought up. Being born at less than or equal to 1,250 grams is not um, imminent death. And that's not because the baby's changed in the last 40 years. It's because we changed. We changed what we do. I think this is a nice illustration of that. You see here survival rates by country. These are a few years dated now. These cohorts come out every 5 or 10 years. And you can see at this time, no longer true, but as of 2017, 0 babies at 22 weeks survived in Australia. It's not because they were particularly different or sicker babies that couldn't survive than in Sweden, where over 50% survived if they were admitted to the NICU. We have certain centers in the country, some of which you might be familiar with, that are really respected for their high rates of survival and low morbidity. University of Cologne is a leader in Germany and in that part of Europe, and the University of Uppsala was really a pioneer in the country of Sweden. University of Iowa in the United States has certainly developed a reputation where Dr. Bandari trained. For having outstanding outcomes, 70% survival amongst admissions in this cohort. And the groups in Japan, there's several, but Nagano and Saitama are very well respected. The entire Japanese neonatal network has over 50% survival. But Nagano and Saitama are highly respected within that group. And you can see here the 90% survival in Nagano. So several years ago, in the absence of clear evidence, our group decided to work together with the individuals at these other institutions to try to understand, what are you doing to take care of babies? Because, hey, I don't have a trial. I can't tell you that anybody's proven that, hey, this is the exact way to treat. But, when you go to Iowa, if you've spent any time there, there's a lot of, sometimes people call them Iowa-isms, things that are a little bit different. And, Dr. Bandari will appreciate this. I would talk to our medical director and say, Dr. Klein, what's the evidence for the parents not being able to hold for 2 weeks? What's the evidence for the duration that we give, fungal prophylaxis? And he'd say, Matt, it's not broken. Don't try to fix it. Look at our outcomes. Well, I read this study, Dr. Klein. Matt, what was their survival rate at 22 weeks in that study? Don't mess with it. So really this group, the hypothesis was, hey, if we can find out if you all do this same weird thing, if you independently came up with it, that's a really good signal that maybe we can learn from. So we've been working together now for about half a decade, all these places at greater than 50% survival. And I've grouped the NRNJ because they're such a great organization that, and the hospitals are relatively small compared to some of the US and European ones. So I usually present them in aggregate. But it's specifically the group at Saitama and Nagano have been the biggest help. This became the genesis of what we now call the Tiny Baby Collaborative. We formalized with the name. We have more than 35 sites, actually about 40. As of next month, we'll have 40. And we have continued to learn from other sites. We've developed observational data sets. You had in-person meetings. You can see the first one here in 2019. Some of the things that we wrote out that we wanted to work on. Um, we started looking at some of the differences in our outcomes, and then I'll show you the differences in our practices. Here you can see at Iowa, you've got NICU admissions, and then the numbers of babies who survived. So almost every baby at 22 weeks, but not all. In this particular cohort, it was all the babies at 23 weeks. Similar at Uppsala, a little bit lower in Cologne, pretty similar in the Japanese neonatal network. And you can see the survival rates. They're all really high. There are subtle differences, but they're all very consistently high. We got together, we said, how do you do it? What are your secrets? Tell us, what things do you think make you better than make your outcomes better than the averages where you practice? And it was interesting. The first thing that everybody said in our first get-togethers was, well, our clinicians know that infants less than or equal to 23 weeks can do well. It wasn't like they had this idea or that they'd read a paper, but it was like they knew. And it was often because at these places, families came back. And so the nurses knew, and the RT knew the baby who had done really well. I think of this text I sent to a friend recently. Hey, how's the 22-week doing? And a friend responded, as expected. So at all of these sites, as expected means we expect the baby to do great. And I think how you answer that and interpret that is really important. All these sites said, hey, another part of our secret, this was surprising to me. These are all really soft things right away that they answered with, but they said, we partnered with parents and families. Nobody had a story like, hey, we had a physician come in once and say, I think we're going to move the limit of viability. I think today we should start resuscitating at 22 weeks. I read a paper. Nobody had that story. Every single place that I spoke with said, hey, we have had no survivors. And, we had this mom, we had this family. Somebody came in and said, I have this situation. There's one story of, the neonatologist gets called by name. And the neonatologist thinks that's odd. Who wants to speak with Dr. So and so? Nobody ever looks for me. So goes to the room, and the mother and the parents say, "Hey, we want to talk to you. We were told that nobody will resuscitate at 22 weeks here. No, we've never done that. We don't think that it's the right thing to do, et cetera, et cetera. We've never had any survivors that young." And the parent says, "You told me the same thing 10 years ago with my 23-week baby, and the baby's doing great." So the doctor says, "Okay, maybe we should talk about this." And so that's a very similar story at all of these places. Partnering with OB has been critical. Everybody's identified that using steroids, delayed cord clamping, having the right equipment. So 2O endotracheal tubes are the ones I think are most interesting because as of a recent survey, only about half of big NICUs in the country had them. But if you don't have the right size tubes and equipment, you really can't provide adequate intensive care. All have very different approaches to ventilation. So different vents, different approaches to even when to intubate. The group in Cologne, Angela Cribbs was a pioneer in Lisa. All the babies do get intubated. They get intubated mostly by the end of the first week in our data collection, but that's how her group manages their babies, and they have outstanding outcomes. So I was intrigued that some of these seem so different, but they all do have in common to avoid overdistension, and that's something everybody agrees on. Because once the lungs are injured, the baby's different. You're managing a very different clinical phenotype. So the goal is prevention. One thing that was really interesting, where all the arrows pointed in the same direction that I didn't expect, is that every single one of our high-performing sites identified use of an antifungal prophylactically, that they'd all had cases of babies passing away from fungal infections, that the risks, we have a paper coming on this, just like early onset sepsis, they're several fold higher at 22 weeks than they are at, say, 25 or 26 weeks. We don't have great clinical trial data on this. You have the Danny Benjamin trial, which was by birth weight, not a lot of 22-week babies in it. And I would never give a recommendation for that, but I do find compelling that all of these sites identified, hey, we have a problem, instituted antifungal prophylaxis, thought that the problem was somewhat improved, and believe that that has contributed to their good outcomes. I think that that's a signal that deserves further study. A similar signal is that everybody said fluid balance is a big deal. The skin is a differentiating characteristic. There's such high insensible losses. So different approaches. Some manage with humidity, some manage with volume, but something is different. Likewise with nutrition, there's much less store of nutrition. So hypocalcemia and hypophosphatemia are common things during the first week that are monitored for at all of the sites. Everybody identified having a core team of experienced doctors and nurses. Collaborating with other specialties, you need to work with your pediatric surgeons or your radiologists in order to provide adequate care. For example, at some centers, cardiology has a really important role if they're doing the echoes, being comfortable to do that on a 400-gram baby. And then I think last, everybody said, when we deviate from the status quo, we keep the data, we monitor it, we track it. So very academic approach. I showed you the survival rates. I showed you that those practices were in common. Here's one of those things that really stood out when we started to look at morbidity. So here you can see differences in the use of oxygen at 36 weeks, so a classic definition of bronchopulmonary dysplasia, as well as an ROP treatment. And so if you look at Uppsala, their rates of ROP way higher than Iowa's. They wanted to know from Iowa, what are we doing differently? Our rates of survival are similar, but we just tell all our families, like 1 in 4 babies has treated ROP. That's obviously not true. We just thought that was the babies. That's how they were made. But you've proven to us that that's not the case. You do something different. Similarly, I was at Iowa when I wrote this, and I can't tell you how many families I said, oh, the definition of bronchopulmonary dysplasia wasn't created for babies at 22 or 23 weeks. Just about every baby I take care of this early goes home on oxygen. And that was true. Look at that. So I kind of had this impression like that's the way these babies are built. That's the only way there is. Angela Cribb's group taught me, no, that's not at all the case. You can go without that, and the babies can survive and thrive. And so I think that there's much to be learned from the big differences in practices across these sites, and we really need to do the research to try to understand these things. So a little bit more on the collaborative. Some of you might have seen some of our webinars. We have one coming up tomorrow on parent engagement in the NICU. Actually, finally getting to that question I asked Dr. Klein about when parents should be able to do skin to skin with the baby. We have given various talks. We have a series of publications. We have a series coming out in Journal of Perinatology this year that you can see. We've done a lot of this benchmarking work, and we've also worked with families. I'll show you a little bit of our work on that. We have a big data set called MINI. We collect from 35 sites in 5 countries, and like I said, it'll be up to 40 now this next month. But as of last October, you can see we had already, had over 1,000 NICU admissions at 22 and 23 weeks. Much to learn. I think just even in an observational sense, this has given us a really good start in being able to compare practices. And for the fellows there, I should point out, it takes a while to get things done. But this project all started when I was a fellow. You might find interesting that it wasn't my formal research, but it was just like a curiosity I had. And I'd gotten to know these groups, and we started to develop the data use agreements and the IRBs so we could share data. And it was like a little side interest just for me to try to educate myself when I was a fellow. It's amazing what can come from a small seed like that. Every oak tree starts as an acorn. As you can see here, what's become really a big data set, and I think will be very valuable. Things that we're already learning from it. About half of the babies at all our sites who are 22 weeks, get intubated with a 2.0. I'm not telling you that somebody tried a 2.5, that a 2.5 could have never fit, but it's interesting when you go to 23 weeks, that drops to about a quarter. So I think there is something about having the right size equipment. This is kind of interesting. These numbers are relatively low, but if you look at Liz Foglia's work for term babies, it's not that much better. Some of this may have been I tried with the 2.5 and then I went with the 2.0 as well. But you can see, the majority of babies, unfortunately, aren't intubated on the first attempt. The majority are on the first two. And just about every single baby is eventually. These are sad cases where it was totally unsuccessful. Something I was taught by somebody once that wasn't true was that it took a little bit longer to regain birth weight when you were this early, and that those numbers that we have don't bear out that you regain your birth weight by the end of the second week. At least in our data set of 1,000 babies, that's wrong. Babies do fit the same the same sort of drop and regain. And we have some emerging data. Noel Young's group at Duke showed if these babies lose about more than 15% of their birth weight, you do see higher incidence of low perfusion morbidities, things like IVH and bowel perforation. So that's, I think, a really important observation. Time to full feeds, you can see here, when full PO nutrition was achieved. Something I found just kind of interesting to scratch my head about. 3 months is the average duration in an incubator before going to an open crib. And that's really, it's a little bit of that's practice variation, but a lot of that's temperature regulation. That's a really long time to be in a really artificial, sterile environment. And some of what we're talking about on the webinar tomorrow has to do with providing adequate parent support and developmental stimulation during a period in which a baby does need a little bit of, ambient climate control to help grow. We have a website if you're interested in our work, tinybabycollaborative.org. You can see all the webinars there. Read some of our publications or get in contact with us if you're at a site that might be interested in joining. And we also have an in-person gathering at PAS this year at Honolulu, if any of you are there, on the Friday of the conference at 7 a.m. When you register for PAS, you need to click the button for the Tiny Baby Collaborative meeting. PAS is checking badges for who comes to join us. So I've told you a little bit about kind of where we are in our field of neonatology, thinking about this from the big picture of our specialty, where these births fit in, that we've gone through some of these issues before. I've hopefully convinced you that tiny babies are not just the same as smaller, extremely preterm babies. I hope that I've given you a little bit of information on what we know regarding practice, which is unfortunately very little. We need better trials, we need more trials, we need more studies. And if you're taking care of these babies in your NICU, I think that that's really our obligation. And the last thing that I mentioned is that we really need to ask families what they need. That's where all of this work comes from. This is because families asked that we could try to best take care of their babies and give their babies their best chance to survive and thrive, and many do. And so here I'd like to let our parents speak. And I want to give a caveat that you need to be very careful. This is a good teacher, Naomi Laventhal, who taught me that you should be cautious about ever starting a statement with parents want, as though a single approach meets the needs of all families. But these are several families speaking from their own perspectives about what they wish people in your shoes would know. Hopefully this comes through.
Is there anything you would like for doctors dealing with premature birth at 22 weeks to know?
I would like for doctors to understand the significance of empathy and compassion. The emotional ups and downs can be overwhelming for families.
Also, we have one tip for the doctors. Tell always the truth to the parents. Also, when it's going a bit bad with the baby or not so good, then it's important to tell always the truth.
この子を通して今までであれば触れてこなかったような人であったりとか、そういった世界であったりっていうのに触れるようになったりだとか、そして今まで当たり前だと思っていたその価値観であったりとか、それこそ 健康とか命みたいなところに関して、当たり前じゃないんだなということを再認識することになりました。
It was extremely difficult for my husband and I to transition to the new normal of NICU life. We had to figure out how to be parents to a premature baby while also parenting our son at home well. It was extremely difficult to balance both home life and also hospital life. We had to learn how to care well for ourselves, for each other, and for both of our sons. There was a lot of fear and anxiety that went into our son's hospital stay. We had no idea what the future would look like, and we had no idea if we would ever bring our son home.
Und die Ärzte sollten die Eltern besser einbinden, Entscheidungen wahrnehmen, mit den Eltern gemeinsam entscheiden und Vertrauen schenken.
親としての心と体も22週、未熟で親になる準備ができていない、整っていない状況であることだったり、出産したから親になれるわけではないこと。
Life. My other advice, and this is from experience, is to be prepared to build relationships with the parents you are working with. This will help you in giving them the good news and the bad news of daily life in the NICU. Thanks so much for your service. You are truly making a difference for future generations.
Is there
Good. So I'll leave on those same points that I hope you take away. I think those are some of the most important things to learn about the care of our tiny babies. Many thanks to the families who were part of the video and many wonderful mentors and people who have supported the work of the collaborative and things that we're learning. And with that, I'll take questions.
Thank you, Dr. Rysavy. That was an excellent talk. I think there are some questions in the chat that are mentioned. The first one, which is also my question, that I think I know the answer, but is there any publication which has outlined differences in approach in any of the centers with very good outcomes, like the mode of ventilation, what settings we should use, and skin fluid changes, etc.?
Yeah, there are publications. I would tell anybody, though, to be very cautious. And the reason for that is that as Angela Cribbs told me, the lead in the unit in Cologne, she said once, Matt, you cannot take an orchid from the Amazon and go plant it in an Iowa cornfield. And what she meant was that you have to do things in the entire ecosystem. It's an ecosystem approach. You have to get the other parts right. So I'm going to give you an example. Iowa has published that they have very good outcomes and that their starting fluid at 22 weeks for parenteral nutrition is 200 ml per kilo per day. By day 3 or 4, typically that will be 300 or 350 ml per kilo per day in their most immature babies. That in isolation would be tragic if you read that and applied it at your site, because what you may not know, and I think one of the benefits of our bigger collaborative and being able to compare and contrast and try to understand the reasons for differences in practices is that Iowa manages babies under an open warmer. And so the relative humidity is about 40% under an open warmer. If you go to Japan and you read the Japanese literature, they say we use starting fluids of around 80 to 100. So less than half of what you're seeing at Iowa. It doesn't mean that, oh, there's 2 ways and it doesn't matter and all these places have totally different approaches. The difference is that in Japan, the humidity is set to 90 or 95% in most of these centers that have reported that. So short answer is yes, you can find single center reports. Some are written better than others. And ultimately, you will find that interpreting them, I think, requires a little bit of finesse, a little bit of caution, because you need to understand the context. Angela Cribbs has amazing outcomes with Lisa, but it's not just Lisa, it's all the other stuff that they do to manage the CPAP on the fresh baby's skin at 22 weeks, etc.
We have a question from Dr. Joseph from the University of Kentucky. Is it known that is any of the variation but for the outcomes for less than 22 or 24 weeks between countries is due to accuracy of dating?
Yeah, it's a good question. And, I think it's when I started publishing with the Iowa group over 10 years ago, that was like the thing that came back in all the reviews. No, this isn't possible. Babies this early don't survive. I'm sure you just date them differently. So just as a caveat, some people may be sensitive to that's happened in some of these other centers. That the Uppsala group had a similar thing happened. You must all just date your babies differently. 22-weekers don't survive like that. But it is interesting to ask that. There's probably differences in other health factors. Certainly there's systems differences. Parents have leave that's state provided in Sweden, for example. So time of skin to skin in the NICU on average per every baby is like on the order of several hours in many of the big NICUs, which wouldn't be the case for many of the babies in my NICU right now in Houston, Texas. You have differences in prenatal care because of different social structures. So yes, there are other factors besides decisions about taking care of, how we as a group perceive intensive care for 22 or 23 weeks that affect the outcomes. And I think those sorts of contextual things are hard to quantify, but are important.
This is one more question from the chat from Joanna. This is similar to the previous question. Is there any difference in approach for the extubation, like time, gestational age, or weight between the centers?
Yeah. And I don't think I have those data in this slide set, but we've analyzed it in the mini data set, and all the centers ultimately intubate all of the babies at 22 weeks. Angela Cribb's center, the Cologne group, people who use Lisa postpone intubation by sometimes several days, but still then there's issues with apnea, for example, and chest wall compliance, and the baby ultimately ends up intubated. The extubation approach is a little bit different in our cohort. I think the places that use Lisa have an average intubation duration of around 3 weeks. And the places that don't, who are intubating straight away, have an average intubation duration, and this is at 22 weeks, of 5-6 weeks, similar to what you saw in the Swedish paper there. And that's very different, again, at 22 weeks than at 24 and 25. And the approach to extubation depends in part on what you go to. NAVA is used actually almost by all the centers in our original collaborative, which is an interesting thing that can help let the baby lead. There's a phrase at some of the Japanese centers that's trust the baby. The baby knows the right rate. The baby knows how big the breaths need to be. And that NAVA allows that. But there is a little bit of practice variation there.
I think this is a follow-up question. There are fellows from other programs which don't have this kind of outcomes. And what would you recommend that fellows learn about the different approaches if they don't have these outcomes?
Go somewhere. Send a cold email. I mean, honestly, so many people are just happy that you care about this, and they want to teach you everything that they've learned. It's not something most people understand or are interested in. And as a fellow, you might underestimate how valuable your time and your interest and how much you're capable of. And so I think just sending a cold email, find those people who wrote the paper or who gave a talk that you were interested in, and ask them, hey, can I come visit you and see what you do? I bet you'll get a lot of yeses.
This is a comment and also my question. So we have a comment from Lindsay Nick, I believe she's at Iowa, and they've started resuscitating 21-weekers at this point of time, since their outcome, their survival is greater than 50% at 22 weeks. And when do you think we'll go to the 21 weeks or maybe 20 weeks? I
don't know. I'm not a good predictor of the future. Ed Bell once, who you know, my mentor at Iowa, cautioned me against that and told me he's on record in the New York Times some years ago saying that 24 weeks was probably the lowest threshold and as low as anybody could ever survive. And funnily now he has this reputation as having, you know, one of the best centers in the country, the world, for survival below that gestation. So I think we should be cautious about what the future brings, but I think we lead by being really observant, by watching the babies, by listening to the families, by doing the research and taking that academic approach so we really know what we're doing and we're not, as you'd say in Texas, shooting from the hip.
This is a question from Dr. Tingui. How do you think about Premilock on 22 to 23 weeks?
What do I think of this? I think I need to be cautious about giving specific practice recommendations, but I will tell you the use of hydrocortisone is very common across our sites in the first weeks at appropriate doses, which is approximately what Premilock gives. When I say appropriate, I mean relatively lower doses. You can see some of Christy Waterberg's early work that was informed Premilock, that much higher doses than that cause a lot more side effects without a lot of benefit. So that like 0.5 to 1 per kilo, Q12, is used at a lot of sites and perhaps to some benefit. But, you know, safety and efficacy haven't been perfectly demonstrated. In Premilock, we have inadequate data on long-term follow-up outcomes. So I think we need to proceed cautiously there, and people need to get those data.
Thank you. I know the questions on the chat, but I do have a question. You have mentioned that 22 to 23 weaker babies are different, but even at here, where I am, I trained at Iowa, but I'm here, we don't have different guidelines for those babies. Do centers, other centers like Iowa and the others you mentioned have different protocols for those babies?
Some settings do, and you have, for example, Dr. Nake, who's on and can speak to what things are like at Iowa now. I am not currently there, but there are certain practices at many of our centers in the collaborative, according to our data and our surveys, that are specific to 22, 23, or 24 weeks. So in-call delivery in many hospitals, delivering the baby still with the amniotic sac intact. For a breech delivery to avoid head entrapment at 22 weeks, practiced by many hospitals, but not at 25. Baby's bigger. And C-section would be the common intervention then. Things like the fluids, and I showed you why that must be the case. The expected duration of intubation, and I showed you why that might be the case. Even initial intubation versus trial on CPAP. At 22 weeks, I showed you the data from Sweden, from across the entire country, and that none of the babies managed to escape being intubated, but a lot of the babies at 25 weeks were never intubated. And by the time you were at 26 or 27, it was a minority of babies who were ever intubated for more than a day.
Thank you so much. That was an excellent talk, Dr. Rysavy, and we are at 4 o'clock, and that should conclude this. Please make sure you evaluate the talk, and either through the QR code or through the link that's given below in the chat. Thank you all for attending.
Thank you for having me.
Matt, just to let you know, you had over 100 people attend today. Over 100 logged in. That doesn't account for people that have multiple people in a room.